I'm Matt Cooperberg. I am a urologist at UC San Francisco in California. I co-lead the prostate program at the UCSF Helen Diller Family Comprehensive Cancer Center. I also have a joint appointment in the epidemiology and biostatistics department. I've been doing prostate cancer clinical care and research since I got to UCSF for training in 2001. Basically, I've been on the faculty since '09. And this is more or less what I eat, breathe, live, and sleep in my professional life. So it is a pleasure to share some updates with you guys. I was actually just down in Orange County for a family event in Newport Beach over the weekend. So sorry we're doing this over Zoom, but maybe in the future I can join you in person. So let me get my slides back up. So I'm planning to talk 30, maybe 40 minutes so we can have some time for discussion and questions and things. But I'll cover a few different topics and updates and kind of risk stratification, active surveillance, focal therapy, and kind of where the field is moving. In case you're not familiar with the most recent data, these are the data that are updated every year by the American Cancer Society. Prostate cancer remains by far the most common cancer diagnosed among men in the US, over 300,000 diagnoses a year. Over 35,000 men are expected to die of prostate cancer in 2025. This is a big number. It's the second highest number after lung cancer, but it's dwarfed by the bigger number of over 300,000. And this, single pair of statistics kind of encapsulates a lot of the controversy that we've been facing over the years in terms of how should we screen and how should we treat this disease. So if we look at these numbers over time, we see some other important trends. So on the left here is incidence. This is the number of cases that we find every year. Going back to the 1970s. And prostate cancer had been relatively stable throughout the 70s and 80s. And then, of course, in the early 1990s, PSA as a screening test suddenly hit the marketplace. And primary care docs were very enthusiastic about this. Every man and his uncle ran out and got a PSA test. Incidence rates skyrocketed because we were finding all these cases, all these men that had been living unknown to them with prostate cancer for years. And we found them. And then things settled out. Throughout the 90s and 2000s, we were kind of at a steady state. And then in 2008, the U.S. Preventive Services Task Force gave PSA screening an I, meaning we can't really make a recommendation, but we don't really think this is a great idea. Then in 2012, they said don't screen anybody ever. And primary care docs got that message, and incidence rates fell off a cliff rapidly. We saw the lowest incidence we've seen since the 1980s. Not because prostate cancer went away, we just stopped looking for it. Because this conversation is driven by primary care, not by urology or radiation oncology or anybody else. Now things are starting to recover. The pendulum is kind of swinging back and forth again. In 2018, there was a C recommendation, meaning, again, we don't think this is a great idea, but at least have a conversation about it. And we are seeing screening rates picking up again because we're much more aware now of how to do screening better and how to make this all make much more sense. Now, in the meantime, mortality rates, these are data that go back to the 30s. Prostate cancer mortality had actually been pretty flat for decades and decades. It started falling in the PSA era, and it fell at a steeper velocity, a steeper clip than any cancer except lung cancer. And we know lung cancer rates fell because of smoking cessation. We can be quite confident that at least half of this decline is because of PSA testing. And when we stopped PSA testing, the mortality decline basically stopped. There are other reasons aside from screening that explain this as well, that exacerbate it. But you can see a few years ago, everybody thought colorectal might overtake prostate as the second leading cause of cancer mortality. Prostate has pulled ahead again, and that is not a good thing. And in the meantime, we know that there is a significant racial disparity. It's actually the biggest disparity for any cancer among any of the major cancers in the United States. Black men face a 2.5x higher mortality than white men. And they're actually seeing this group is seeing a higher rise in mortality rates than anybody else. And over the years, we've seen similar declines in mortality for white and black men, but the gap, the delta, has really not gotten any narrower. And this is that, what's called the rate ratio. So 2.5x excess mortality year after year, decade after decade, and this really has not gotten better. And at the root of it, the fundamental problem here is that we use the word cancer for an unbelievable spectrum of things that can happen to a human body. You and everyone on this call and me and everyone else is growing rogue cells every single day in lots of organs in your body. At some point, some of these become histologically funny looking under the microscope, and it's only a minority of those that will ever actually get the capacity to grow and spread. The word cancer goes back literally 2,500 years to Hippocrates. We've been thinking about this as a clinical syndrome that kills you for literally millennia. For about 150 years, we've been looking under the microscope and saying, okay, well, the tumor that grew in the breast looks like this. The tumor that grew in the prostate looks like this. But it was still something clinically detected, something lethal. It is only in the last few decades that we've been screening. Pap smears came online in the 60s and 70s. Mammograms, colonoscopy shortly after that, sort of 70s and 80s, PSA testing again in the 90s. So it's a very recent phenomenon that we get little snippets of tissue from people that are living with absolutely no symptoms, handed off to the pathologist, and they say, well, this looks like the thing that 30 years ago would have killed the person. We're going to call it the same thing. And we have a nomenclature problem. We are giving people diagnosis of cancer that really should not have it. And if we think about screening for any cancer, this can be PSA testing, mammography, colonoscopy, whatever you like. You get periodic testing over the course of your life. If you get to the far right, you've died of something else, usually cardiac disease. That's what kills most people in this country. If you get to the top, you've actually died of the cancer. And we know that even with screening, there's a lot of people that have cancer cells in the prostate and other organs that we never find, and that's a good thing. If you live long enough, most men will have funny-looking cells in the prostate. Okay, we don't worry too much about these. Then there are the tumors, the low-risk ones that we can find when it is confined to the prostate. We can cure it, but had we never found it, you never would have known you had it. No symptoms, no threat to life for the rest of your life. We can only do harm in treating these low-risk ones. We cannot do benefit because it had no clinical capacity to cause problems. Then there's the rabbits, the ones that we can find when it was in the prostate. Had we not found it, it would have caused a slow, painful death. But the fact that we found it, we were able to cure it. And this is how we've been able to drive down the mortality rates, is finding the rabbits. And then there's the so-called interval tumors. The PSA was 0.6, then it was 0.8, then it was 3, and it's already too late. This is actually very uncommon in prostate cancer. This is common, say, in pancreatic cancer. That's why we don't screen for pancreatic cancers, because they grow very, very quickly. Prostate cancers grow over decades. So the birds are very rare. We don't really care about the snails. The tension is all about the rabbits versus the turtles, and how many turtles have we squished in the course of chasing rabbits. And just to emphasize the point about the snails for a minute here, this is a summary of autopsy series. So men that die in car crashes or heart attacks, whatever you like. By the time you get your 70s as a black man in the US, your 80s as a white man in the US, 50% of all men have what looks like grade group 1 prostate cancer under the microscope. So you can almost think about this as a normal feature of aging. Men that have a grade group 1 only diagnosis really should not be thinking of themselves as cancer patients. Certainly not the way we've defined cancer for the last 2,500 years. And frankly, we're trying really hard at this point not to find the grade group 1 cancers. So I'm not sure what the diagnostic paradigm was like for all of you on this call, but these days in contemporary practice, if you have an elevated PSA, we typically do not rush to biopsy unless the PSA is really, really high. If the PSA is in the 4 to 10 range, we now have 7 different urine and blood tests. We have MRI, we have genetic tests, we have more tests than we know what to do with, all designed to identify higher grade cancer, grade group 2 or higher, 3+4 or higher. The implication is that if the test is negative, either there's nothing there, or there is no more than grade group 1 or Gleason 3+3 cancer there. And in either case, we don't do the biopsy. So we're actually trying pretty hard not to find grade group 1. So we certainly should not be treating it if we happen to find it. This is what we call an incidentaloma, similar to, say, a small kidney tumor that we find because somebody shows up in the ER with belly pain and we do a CAT scan. And this is working. When I started doing broad research in terms of broad treatment trends across the US, when I first got to UCSF, we had a great data set that showed us in the 90s, almost half of all prostate cancers that we found in the US were low risk by the turn of the century. These days, in a large registry that I helped the American Urological Association start, it's down to about 20%. And if you go to other places like the UK, where nobody gets a biopsy that does not have an MRI lesion, the rate of grade group 1 is down to about 7% of all prostate cancers. So we're really trying not to find them. And this message is really important when it comes to primary care, because we obviously in urology and oncology, radiation oncology, we spend a lot of time in research trying to improve treatments and trying to improve survival for men with diagnosis. We're trying to improve surgery, radiation therapy. The progress in terms of management of advanced disease for men that have bad prostate cancers is fantastic. Better treatments every year. But the reality is this is all relatively incremental. If we want to save tens of thousands and hundreds of thousands of lives in terms of men with prostate cancer, we need to screen better. We screen fewer than 50% of all men before the age of 70. We really should be screening around 45 to 55, and the only way we can do that is by convincing our colleagues in primary care that we have no interest in finding, let alone treating, the low-grade ones. And we actually finally got this baked into our electronic medical record system across UCSF Health, is in collaboration with our primary care doctors, based on this messaging about non-overdiagnosis, non-overtreatment. This message has finally kind of gotten through, and this is now policy. So men are offered screening, or at least had offered a discussion about screening, between 45 and 75. If the PSA is under 1, never mind 4. If it's under 1, you're done. You can be done for 20 years, but we can say for sure you're done for 5 years. If it's marginal, you should recheck it, or maybe we think about early workup. If it's over 2 for younger men, over 3 for higher men, we should work this up. Not biopsy, but proceed with MRI or secondary testing. And if we find cancer, we only treat if it is high grade. So which ones need treatment? How do we know what's aggressive and what's not aggressive? So, as I've already said, most men with prostate cancer, you'd never know you had it if we had not found it. And most men with prostate cancer, of course, ultimately die of other causes. However, the aggressive ones can spread, and they need to be found through screening. They need to be treated aggressively before this happens. And we have known for literally decades at this point that we should be managing every prostate cancer with a risk-adapted paradigm. Low-risk disease, active surveillance, slightly higher risk. This is where focal therapy comes into play. We have surgery and radiation therapy for solidly intermediate risk cancers. We will often combine those for high-risk disease. And it's really only the really aggressive ones that are already metastatic at diagnosis that we treat with systemic treatment alone. So how do we do risk stratification? Well, we think about all the factors that we know about the PSA, the grade, how many cores are involved, et cetera, to try to figure out the likelihood that this cancer might spread. That's what really matters with a cancer. It's not will it grow in the prostate, it's can it spread to other parts of the body. And we can do this clinically. We can also use other tests like genomic testing to help us do this a little bit more precisely. So what does this actually entail? You may have heard about the risk groups from the National Comprehensive Cancer Network, the NCCN. These are used very commonly in clinical practice. They're honestly quite cumbersome at this point, and they're not that great because there's a huge amount of heterogeneity within each of these boxes. The notion of a very low risk group is actually dying. This is going away. This is out of the AUA risk group at this point, and I've heard rumors the NCCN will drop it as well, which is a good thing. Because the problem with the very low risk group is if we have a very low risk group and you're low risk but not very low risk, men have this anxiety saying, I'm not in the lowest risk group, I need to get treated. So low risk is PSA under 10, grade group 1, low stage, period. PSA density doesn't really matter. How much grade group 1 doesn't really matter. Age doesn't matter. Low risk disease, surveillance, period. Favorable intermediate, if the PSA is a little bit higher, you have grade group 2, but still low volume. Then it's called unfavorable intermediate if you have more than half the cores involved from a biopsy. This becomes a problem because if you have 7 out of 12 cores on a biopsy and it's all grade group 1, that is absolutely a low-risk tumor. Okay, but the minute you have like a speck of 3-4 in there, this gets called an unfavorable intermediate. If you are going down the radiation path, you're probably getting offered 2 years of hormonal therapy. It's a big deal. So we need to do this all a little bit better. At UCSF, we published the CAPRA score literally 20 years ago now. This is based on the same basic risk parameters, PSA, Gleason stage, number of cores involved. It gives us a 1 to 10 score that is very, very effective in risk stratification. This is just looking at the CAPRA score here. Patients with low risk disease, basically nobody dies of prostate cancer. We've actually pushed these curves out to 20 years now. If you've ever seen one of these Kaplan-Meier curves, the idea is you want to stay at the top. This is 100% of men are still surviving the cancer. If you're down here, it means 95% of the men are still surviving the cancer at 15 years. So you want to stay up at the top of this diagram. Low-risk disease, most men do stay up here. For high-risk disease, the highest risk levels, half of the men have died of the cancer by 10 years. And at a glance, we can look at 2 sample patients here. The one on the left, who has a low PSA density. That's the PSA divided by the size of the prostate, acknowledging that a big prostate can drive the PSA up. So low PSA density, low stage. It's a grade group 2, but there's not very much pattern 4. It's only 10% of the cancer is pattern 4. Fused gland subtype. This is technically unfavorable intermediate. But this guy, I would say, is a chip shot for active surveillance. That is the thing he should do. The one on the right, on the other hand, much higher PSA, high PSA density, higher grade cancer, higher volume, and it's one of the more concerning subtypes of pattern 4, cribriform, intraductal. These guys are in the same category according to the NCCN. We can certainly identify them as different according to the CAPRA score. And at a glance, I would say the one on the right not only needs treatment, but is at actually pretty significant risk of having metastatic prostate cancer. And he's someone we would do PSMA PET testing, for example. It is critical to remember that even the bad ones, nearly 100% of men are alive at 5 years, and that these survival curves look better every year as we screen better, as we find these better, and as the treatments improve. So let's focus a little bit on what we're learning about active surveillance and how we do surveillance. So active surveillance is, first of all, I should say it's different from watchful waiting. People often conflate those terms. And the idea of watchful waiting is an older term which would say, listen, Mr. Jones, you're 82 years old, you've got this little prostate cancer, but you've already had 2 strokes and your heart's a little shaky. We are not even going to worry about the prostate. Go home and forget about this. If by some poor luck you show up with bone pain from a progressive cancer in the future, we will put you on hormonal therapy. But we're not really going to worry about treating this now or thinking about curing it. Okay? Active surveillance is a very different concept. Active surveillance is relevant for men at any age, even with a very long life expectancy. What active surveillance says is that we know the window of opportunity to cure prostate cancer. We can measure in years or even in decades, and that we have very good tools to identify early signs that the cancer is progressing, and that we can capture the vast majority of these well within that window of opportunity for cure. And that when we start on active surveillance, we have every intention and expectation of still curing the cancer if we start to see signs that it's getting worse. So active surveillance does not mean you never need treatment. It means we're not going to treat it now. You may need treatment someday, and we think we're going to have every prospect of curing it if we get to that point. And it's great to say that surveillance is the standard of care for low-risk disease in 2025. It's still used kind of variably. And just to illustrate that point, these are data from that same registry with the American Urologic Association. This represents about 25% of all urologists in the country. As recently as 10 years ago, only 25% of low-risk disease was getting managed with active surveillance. That's the green bars here. We've seen rapid progress, and by the start of the current decade, we're up to 60%. This is still much too low. We should be at 90% or better, but still, it's progress in the right direction. If you look at variability, though, here we are looking at individual urology practices along the X, individual urologists along the Y. And each circle here is a urologist within a practice. And the bottom line here is that depending on which practice you go to, which urologist's door you happen to knock on, your likelihood of getting surveillance for low-risk disease ranges from 0% to 100%. Okay, that is obviously a massive problem. Now, this is not unique to urology or to prostate cancer or to active surveillance. This is called the small area variations problem. We see it ubiquitously in healthcare, anywhere we have the courage to pick up the rock and look and see what's under it. Okay. However, this is a huge problem, and it is a huge problem, and this is why we universally recommend, second opinion at an academic center if there's any question about the right thing to do for a new cancer diagnosis. And prostate cancer is never an emergency. Even given a high-risk diagnosis, you have time, unless we're talking about cord compression from widely metastatic disease. Okay? So who's a good candidate for surveillance? Basically anybody with low-risk disease. And when I say low risk, we've got the NCCN criteria. So PSA under 10, Gleason 3+3, clinical stage T1 or 2. These days, I would honestly say anybody with grade group 1 is a candidate for surveillance, period. If it's a 3+3 and the PSA is 12, I don't really care. If there's 8 out of 12 cores positive for grade group 1, I don't really care. You can have a prostate completely replaced with grade group 1. Nobody dies of prostate cancer. Grade group 1 has never killed anybody ever in the history of, all the time we've been studying this disease, if it was a pure grade group 1 and it was graded according to a current standard. None of them has ever metastasized. None of them has ever caused lethal disease, regardless of how much cancer there was, regardless of the PSA. So a growing subgroup of men with intermediate risk disease, we think are also eligible. So this is Gleason 3 plus 4 with so-called fused gland or poorly formed gland subtype. I've mentioned the subtypes a couple times. This is a really important concept. So there are different versions of pattern 4 that the pathologists identify under the microscope that get lumped into pattern 4. These are just different patterns of the cells. When we talk about Gleason score, what we mean is how the glands look under the microscope to the pathologist. And we are now in prostate, specialized pathology circles, they're now giving us these subtypes. And we know that some of them are quite aggressive, large cribriform, intraductal. Some of them are really not aggressive. The fused gland, poorly formed subtype, poorly formed gland subtypes of pattern 4. And these both biologically and clinically behave a lot like the grade group 1s, the 3 plus 3s. And we are putting these men on AS. I'll emphasize again, age is not a factor. The only way we can screen men in their 40s and 50s with a good conscience is if we are 100% sure that we are not going to overtreat them if we find low-risk disease at an early age. The younger you are, the more likely you're going to need treatment at some point, but I would much rather have my prostate out at 65 and 55, and I'd rather have it out in 2040 than 2030, frankly, because science continues to get better and treatments continue to improve. Do we need imaging? We do not need to do bone scans or CT scans. We usually don't need PET scan either. We're doing a ton of PSMA PET testing for high-risk disease, but it's not usually necessary for low or favorable intermediate risk disease. On the other hand, confirmatory biopsy and a high-quality multiparametric MR really is essential. And MR is one of these tests that really does require a high level of expertise. It's slowly getting better in community practice, but there is tremendous variability from place to place in terms of how well MR is done. Look, even at Stanford University, they did a great study at Stanford recently. They're a high volume prostate cancer center, maybe not quite our level at UCSF, but still very good shop. They did a really nice study a couple of years ago of the likelihood if the radiologist called a PIRADS 5, meaning if they gave it the highest score on the MRI, what is the likelihood of actually finding a high-grade cancer when we go to do a biopsy? Depending on which Stanford University radiologist pulled your scan off the top of the queue on a Tuesday morning, that likelihood ranged from 40% to 80%. Okay, that's huge variability. I'll tell you the situation is completely different at UCSF because we have not yet had the courage to do the study. Okay, this is true everywhere. We have seen a colleague of mine who's now at UW, used to be at UCSF, and Antonio Westphalen, did a similar study from center to center. And depending on which center you're at, that prediction likelihood, high-grade disease, ranges from 25 to 75%. So where the MR is done is incredibly important. This, by the way, is ground zero for AI. As you might imagine, there are algorithms coming hard and fast, which already there's a version 1 open source AI algorithm, which is out there called PyChi, which has already been shown to beat 75% of experienced human radiologists in predicting high-grade disease. So this problem is going to be solved for us relatively quickly, I think. So once we've got the diagnosis, how do we follow it? Well, we typically check a PSA every 3 months for the first year and then back off to every 6 months. You really don't want to do it too frequently because, of course, PSA, being prostate-specific antigen, is also patient-specific anxiety. The less often we check it in some respects, the better for low-risk cancers. It is really, really important to do a confirmatory MR and biopsy within 12 months, especially if the diagnostic biopsy was not done at a high-volume center of excellence, because we know that things are missed. We talk about grade group 1 being indolent. The reason we see some of them progress quickly is because there was something bad there that was missed on the diagnostic biopsy. So it's very important to make sure that we did not miss anything. And then after that, we try to tailor the frequency of how often we do imaging, how often we do biopsy based on individual cases. And we use genomics selectively. Okay. So do we need to do genomics? Do we need to do other tests? Here we have 3 tests that have been around for a long time: Polaris, Decipher, Oncotype. These are all tests looking at RNA expression in the prostate cancer tissue itself. The one we have by far the most experience with at this point is Decipher. There's also a new test called Artera, which you may have heard of, which is a pathology AI test, which is kind of rapidly hitting the market. This has no role yet in the active surveillance space, but we are working with them pretty closely at UCSF, and it's coming fast, as are other companies developing pathology AI tests, kind of like the radiology one that I just mentioned. So not everybody needs these tests done, but they can be very helpful for borderline cases. Where there is 3 plus 4, where there's a really strong family history, where 12 out of 12 scores are positive for 3-3, PSA is rising quickly, where, cases where things don't feel quite right, we're not quite comfortable, these tests can be quite helpful. But it does not mean that you need to rush forward and treat just because you have a high genomic test. So we have to be very careful about how the results are used. We already throw 12 different numbers at you when you get a prostate cancer diagnosis. Okay, the PSA, the CAPRA score, Gleason score, nomogram scores, shins for sexual function, et cetera, et cetera. Now we give you a Decipher score. Have we solved the problem? And the answer is probably not, because even the docs don't know how to use this half the time, more than half the time. Just running a genomic test does not necessarily answer the question. And the reports, quite honestly, are not great. All these tests get developed in very close concert with academic specialists in terms of picking the genes that matter, validating these tests, showing that they work. But then the reports get drawn up by the marketing departments, and there's really no vetting and no science behind them. And some of them are actually kind of dangerous. The Decipher one, for example, I ignore everything here except for the number. This is all that really matters. I don't really care about these thresholds for low and intermediate risk. These are kind of arbitrary. This is definitely a continuous variable. And there's a big difference between 62 and 92 in terms of risk. And I ignore these numbers completely. These cause a lot of anxiety because they're based on patients who were diagnosed decades ago. This is not reflective of what we would expect today. The Artera test, Artera is brand new on the scene. They have published 0 data points on active surveillance, and yet they've got this little active surveillance box here in the corner. This is completely inappropriate. And I've said this to the company. I'm a fan of all these tests. I think there's a lot of excitement around Artera, but what Artera does so far is tell you if you need hormonal therapy, if you're going down the radiation path. It absolutely cannot guide you in terms of active surveillance decision making. Even worse is the current version of the Polaris test. Based on the Polaris, it is trying to tell you what to do. Okay, this guy should go on surveillance based on his Polaris. That is completely inappropriate. Okay, every one of these tests is a data point, and it is our job in logic practice to integrate these results with everything else I already knew about you, your PSA, your family history, your Gleason, your own preferences for treatment, your anxiety level, to try to paint this picture that you should do this because this single test is not the way these tests can be used or should be used. Okay, and I always make this joke. I mean, everybody wants a pregnancy test, and if it turns blue, you take out the prostate. Like, it's just not that easy. That's not how the biology works. It's not how clinical medicine works. And as much as this is how everybody wants the tests to work, this is what we really have is the equivocal pregnancy test. Okay. Surveillance itself is honestly very, very safe. Obviously, every time we do a transrectal biopsy, there is a low risk of infection. There is still a risk with transperineal. It's probably a little bit lower. On the other hand, the transperineals are definitely more uncomfortable. So, there's a lot of controversy about transrectal versus transperineal. I'm happy to take questions on that when we're done if you'd like. I'm still doing the majority of mine transrectal, frankly. But we're doing more and more transperineal, I think, across the whole field. People ask if biopsies spread the cancer. It does not. There are case reports of this. I mean, I'm talking about 2 in millions and millions of biopsies that get done. There is always the theoretical risk of missing the window, okay, of not the cancer got worse, because in most cases, the cancer got worse. It was kind of bad to begin with, and it just took a while to find it. The cases where it was curable a year ago, and now it's clearly worse, and I wish we'd done something a year ago. That happens. Okay, mathematically, it happens more often than never, but it's very uncommon. We're talking 1% less in a year of surveillance. It's far less than the risk of harm by rushing right into treatment for low-risk disease. And then, of course, there is the anxiety question. We hear all the time, this guy had low-risk disease, couldn't sleep at night, and we're going to go to radiation therapy because he just will feel better. That is a bad excuse, and that is a failure on our part to do a better job in counseling. Okay, the guy that's rushing to treatment because of anxiety needs to spend more time, across the table from me in clinic, across a Zoom from me, and really come to understand what this is and what this isn't. Again, the word cancer has this resonance that really does not apply in many prostate cancers, and certainly not in low-risk prostate cancers. People hear the C word and they think they're dead in 6 months from a lethal disease, and that is not what this is. How long can you be on surveillance? That is a moving target. At UCSF, we have over 2,500 men that have gone down this path. Generally, about half get treated within the first 5 years, which means half don't. We're trying to really push the envelope in terms of who can stay on surveillance. We're constantly refining the approach to the question. We want to do as few biopsies as possible. And we were really looking to keep men on surveillance. In the old days, the minute you had a little bit of grade group 2, spec of 3+4, well, now we go to treatment. Now we don't anymore. So we're managing to keep men safely on AS much longer. So this is one version. This is very much kind of my opinion, although I think it's not, it's not that far off from the way many of my colleagues are practicing these days, which is that, if you've got a low volume grade group 1, this is the one that we really shouldn't call cancer. 2 cores of 3+3, 5% of the cores involved, PSA density is like 0.03. We do a confirmatory biopsy, it's negative, or we find the same little speck again. Here, if, this is an older patient who, maybe doesn't have 30 years to live, we honestly can just stop. Okay, this is where watchful waiting is actually quite appropriate. More typically, and this patient with a short horizon probably shouldn't have had a PSA test in the first place, by the way. Like PSA testing is relevant for men, screening is relevant for men who have at least 15 years in front of them. But this does become a quite a relevant question as men get, 5, 10, 15 years of surveillance under their belts. We do start to have this very important conversation. When can we stop? Okay, when is it becoming very clear that the prostate is not going to be what gets you? And can we stop worrying about it? Right? And that's a difficult thing to pin down for anyone, pin down in the slide. That's very much individualized and a conversation that we have with men as they age. More typically, we're really trying to do kind of a de-intensified surveillance pathway these days. We're focusing on PSA and MRI and doing fewer biopsies where that is safe once we've done the confirmatory biopsy. And things are more borderline. High volume disease, we do have grade group 2, maybe there's a family history of lethal disease, there's a larger tumor on MRI. Well, this is more of a standard surveillance protocol such as we might have seen 5 years ago. So yeah, you need a biopsy every couple of years. We're not going to skip MRIs because something is probably going to happen at some point. And then there's the men who frankly are not good candidates for AS. Okay, they've got a real 3+4, they've got a little bit of 4+3, maybe they have a BRCA mutation, so they're at higher risk genetically. Maybe they have one of these adverse subtypes under the microscope, like cribriform. They've got a bigger lesion on MRI. We tell them they really should get treated, but they really want surveillance. I will say sure, as long as you understand treatment is a question of when, not if. And patients in this category here, there is a real risk of missing the window. Okay, it's still not 30%, but there's a real possibility that we're going to regret it 3 years from now or a year from now when when things are clearly worse. And along the, from any of these boxes, we can decide to treat at any point, or men cycle through surveillance, and they can move to a more or less intense surveillance path as appropriate. And this is exactly where the segue to focal therapy comes in, actually, because when you think about this box down here in particular, this is who I think of as kind of relevant for focal therapy, or maybe some men in this box here. Focal therapy, which means treating anything short of the whole prostate, has been around as a concept for decades, but honestly, it has never been studied well. So it has never made its way into the guidelines, and we have never really figured out exactly how to do it properly. Part of the problem is that over a lot of years, it was really kind of held up against surgery and radiation therapy. And the problem there is the studies are kind of impossible to do. If you run a trial of focal therapy versus surgery or focal therapy versus radiation therapy, you have one of two choices. You can do this with a quality of life outcome, in which case I can tell you before we started that the quality of life outcome will be better in the focal therapy group by definition. It will have fewer quality of life impacts than surgery or radiation therapy. But if you want to really say, is this oncologically safe? Is it managing the cancer safely as would surgery or radiation therapy? Come back in 20 years and I'll give you the answer. And nobody wants to run a study that's going to take 20 years in this space. So no good trials have really been done. And I will say, many of us, this is not universal, but many of us that are doing research in this space are really coming to realize that focal therapy should not be thought of as a replacement for surgery and radiation. It should be thought of as an adjunct to active surveillance. Part of the issue is that we've had an inconsistent use of terminology over the years. We can think about focal therapy as just treating a tumor or treating a piece of the prostate. It could be hemiablation, treating fully half the prostate, or even treating more than half the prostate and just leaving one of the nerve bundles alone. All of these kind of get conflated under the term focal therapy, which makes it even harder to study. And there's many, many different ways to do this. The one we're doing most these days at UCSF is called HIFU, high intensity focused ultrasound. This is a transrectal delivery of high-intensity ultrasound to basically heat up an area of the prostate and destroy the tumor that way. We can do it at the opposite end of the thermal scale with cryotherapy. These are probes placed through the perineum, through the skin under the scrotum, instead of energy transrectally. This is what we did for many years, and we still do this occasionally. It's just a little bit harder to monitor in real time than HIFU, so we're doing less of it these days than HIFU. There's IRE. This is irreversible electroporation. It's using electrical energy, again, transperineally to destroy the tumor. There's focal laser ablation. This is another transperineal one, which is literally using laser light to destroy the tumor. I don't care in the slightest about the energy modality. Okay, there are some edge cases where one of them may be better than the other, but the reality is we have had there's photodynamic treatment, there's alcohol ablation, there's eye of newt. There are many ways to destroy a piece of the prostate. The question is, do we know what piece of the prostate we should be destroying? And this goes back to the imaging question, the MRI question that I mentioned earlier. And the answer is often we do not. Okay, and that's the biggest issue here, is that we are not yet at the point where our imaging consistently and accurately captures the totality of the tumor. We know that the worse the cancer, the more likely it is that the MRI spot underrepresents the extent of the cancer. So the situation that we're in is that focal therapy is really associated with very few side effects. People do fine. They might have a little bit of urinary obstruction early on. There's usually a pretty minimal impact on sexual function. So those are all good things, but the rates of recurrence are quite high, 30%, 50%, maybe even higher. And we're basically saying that's okay because we're not burning any bridges, and we can come in later and do more ablation. We can do surgery, we can do radiation therapy with, again, every expectation of curing it. And we see these recurrences both in and out of field, meaning in some cases we see a recurrence right inside the zone of ablation, which means, well, I guess we just didn't get enough heat in there or enough ice in there. Or we'll see it at the edge, meaning, okay, our ablation zone probably wasn't big enough. Or we see it somewhere else. Prostate that grew one cancer grew a brand new cancer. So no matter what, if you go down the focal path, you are definitely committing to long-term surveillance because the focal therapy might not work 100%, or the prostate could grow a brand new cancer. So without question, you need a biopsy at the 1-year mark. There are protocols to try to follow this with PSA or imaging. Those are explicitly shown to not be adequate. You need the 1-year biopsy to be sure that the ablation was successful. And we will sometimes explicitly leave 3+3 on the other side and all that. That's all fine, but it still needs to be followed. So we had a consensus statement across the 5 University of California campuses a couple of years ago on this, which is that, look, we need to acknowledge focal therapy is still a little bit investigational when we talk to patients. We ideally should be doing it under the auspice of a clinical trial, or at least a registry, as much as possible. Who is a good candidate? Well, again, you need at least a 10-year life expectancy, or you shouldn't be bothering with the prostate at all. This should be grade group 2, or maybe a low volume grade group 3. We should not be treating grade group 1 with focal therapy. That's overtreatment, no less than surgery. And it should be imaging visible. So on either MRI or ultrasound or both, we should be able to see the lesion, and there should be no more than a little bit of 3+3 somewhere else that we are not treating. Ideally, it should be low stage. We'd like to see a PSA under 10, or the PSA can be as high as 20 if the PSA density is low. And again, you have to have the confirmatory biopsy before committing to focal therapy to make sure we know what we're targeting, and you need the biopsy at the 1-year mark. So I will sum up there. These 2 QRs here, the one on the left is our website at UCSF. We've actually just updated it with our patient advocate group at UC. I've written a lot of this material. And on the right is a kind of prostate cancer 101 video series that I've done, which you're welcome to look at as well. So with that, I will stop and take questions. There is already one in the chat, which I'll start with. So feel free to put questions in the chat or just kind of call out. So the one in the chat here is about the PROTECT trial and how it informs the potential benefit from focal therapy. Okay, so PROTECT is a whole nother conversation. So PROTECT, for those that are not familiar, is an amazing randomized trial that was run in the UK, where men actually agreed to be randomized between radical prostatectomy, open, versus radiation therapy versus what they called active monitoring, which was basically watchful waiting. They followed men with PSA and only did biopsies for cause. So men agreed to this randomization, and they got something like 70, 80% of the men eligible for the study to accept randomization. The way they did this is none of the physicians was allowed to talk to the patient until the study nurse had gotten to them first and said, "We do not know how to treat prostate cancer. We would like you to participate in this study." And it's got something to do with the psyche, I think, in the UK versus the US, but it's also got a lot to do with that process. Neither the urologist nor the radiation oncologists were allowed to give their biases before the men had decided if they liked the idea of randomization. So Protect was pretty successful. Now, there was a fair amount of crossover. Some men were assigned to surgery and then decided they wanted radiation or vice versa. But still, they got this done. Out to 15 years, what they've shown is that there is no cancer survival difference across the three arms. Okay, we are starting to see some daylight, a statistically significant difference in terms of progression to metastasis between surgery and radiation versus monitoring. So there is a slightly higher risk of progression to metastasis in the monitoring arm. However, there's two big caveats there. First of all, this was not a low risk only cohort. This was offered to any man with lower intermediate risk disease who was willing to be randomized. So about 75% of them were low risk, about 25% were intermediate risk. And you have to remember these were patients from the early 2000s. So these were biopsies done without imaging guidance. They were done often at kind of secondary urology practices. This was not all academic centers. It was a 10-core standardized biopsy. And we know from the subset of men that went to surgery, some of them were grossly undersampled. The results for active monitoring, without question, are worse than we would expect to see today with a contemporary active surveillance protocol. Now, the other comment about Protect is held up by especially some of the radiation oncology community to say Protect proves equivalence between surgery and radiation therapy. In fact, it does absolutely no such thing. There is a tenet in healthcare that absence of a proof of difference does not prove absence of a difference. Okay. And even at 15 years, there are very few actual deaths in the surgery and radiation arms. And the other problem is that the analysis is all done according to intent to treat. What that means is the analysis is done according to the group that you were randomized to, not the treatment that you actually got. And there are some good statistical reasons to do this, but it can obscure real differences. And in the 10-year outcomes, I know this is long-winded, but there's some important points. At the 10-year outcomes mark in Protect, there were only 5 men in the prostatectomy arm who died of cancer. There were only 4 men in the radiation arm who died of prostate cancer. And there was even a letter to the editorial in the New England Journal saying, see, this is a trend favoring radiation therapy. It's nonsense. And it came out later that of the 4 men who died of prostate cancer in the radiation arm, all 4 of them got radiation therapy. Of the 5 men that died in the surgical arm, only 2 of them actually got prostatectomy. We've not seen that update yet at 15 years, and they're gearing up now for the 20-year outcomes. Many more men hit a biochemical recurrence in the radiation arm than the surgical arm. And if you know how we define recurrence after local therapy, it is much more difficult to hit the Phoenix definition for radiation, meaning if you hit biochemical recurrence in radiation, after radiation, you're much more likely to actually eventually get a metastasis than if you hit biochemical recurrence after surgery, which is just 0.2. So Protect is an incredibly valuable study. We're going to continue to learn from it for years. As far as focal therapy, it probably doesn't tell us a tremendous amount because focal therapy was not yet on the radar at that point, and none of these tumors was imaging detected. The UK is now the international global advocates for imaging. And some of those guys literally say this should be an MRI-defined cancer, not a pathology-defined cancer. I think we're not there yet. And I've had lively debates with these guys, and they're wonderful researchers and clinicians and all that. We're not ready yet. They're also incredibly aggressive about focal therapy. So they have protocols there that they will treat any Gleason 7, so some pretty significant 4+3s. They're treating with focal. Again, I think they're a little bit crazy, but a lot of things get called crazy until they're a standard of care. So, we will see. So, Protect itself, I think, does not tell us much yet, but there are other trials. So the PART trial, which is, they randomized to surgery versus focal therapy. There's other ones in process in the UK that are going to be very, very valuable. Is work being done to assemble statistics for the situation of recurrence when surveillance might be appropriate? Yeah, so if I understand the question correctly, there's actually multiple efforts where groups are pooling data across multiple cohorts to try to figure out the best way to do active surveillance. We've
This
actually
is
looked
in recurrence. If you're already in recurrence.
Oh, sorry. Yes. Okay. Yeah. Sorry. Yes. Great. Different question. Right. So
forwarding. forward my part.
Yes. Yes. Gotcha. So that's a great question. And there was a nice analysis from the SysNet group, who were some really crackerjack statistical modelers out of UW and Fred Hutch at UW and University of Michigan and Erasmus. They've got this consortium of statisticians. And there is a really solid estimate based on data from UCSF and Hopkins and two other centers that we overdiagnose at least 30% of recurrences after prostatectomy in particular, meaning the PSA goes up, but as far as I've heard, nobody has ever died of a PSA. Okay, so it is difficult because PSA does drive anxiety. Okay, and it's hard to watch the PSA continue to go up and up and up. This is where I do think genomic testing is very helpful. So for men that have a recurrence, this is where I do get a decipher test typically. And if it's low, I am much more willing to watch the PSA drift up for longer than if the decipher is high. We've got some pretty good data. If decipher is high, then we really do want to treat at a relatively low PSA. We've got great data that we never need to do adjuvant therapy, meaning treat just based on the pathology report. We can pretty much always wait until the PSA gets to 0.2. And these days we want to wait until 0.2 after surgery because we want to get a PSMA PET test to see if we can identify the recurrence. After radiation, it's much harder because we're still using this definition, this Phoenix definition, which means you have to let it go up by 2 over the nadir. That is way too conservative. If, by the time you hit that definition, we've often missed the chance at salvage surgery or salvage radiation therapy. So that's a moving target, how we should better define recurrence after radiation and surveil patients who do have a rising PSA after radiation.
Doctor, thank you. I know that Dr. Metzger there is eager to tell you how excited. This was, shall I say, almost exhilarating. So thank you very much for that. I'm going to turn it over to Dr. Metzger.
Yeah, please.
Chuck?
Yeah, is the voice on?
Voice is on, yeah.
Okay. Yeah, well, that was just wonderful. It just good news for a lot of situations that we encounter here. We have a lot of men that are on active surveillance. I just have a question before you go on to other questions, but we've been hearing a lot about micro ultrasound, 25 megahertz. Is it going to replace MRI, hopefully?
Yeah, well, the answer is two answers. It probably could and it won't. Okay. I think politically and economically and the state of the field being what it is, the number of MRI scanners that are out there versus the number of micro ultrasound scanners that are out there, MRI is not going anywhere. And MRI is going to get better. It is, we go around the world, MRI costs about 300 euros or 300 pounds or whatever. It's a cheap and accessible test. Here we charge thousands. It's insane what we pay for imaging in the US. If it ever becomes as inexpensive as it is in most of the civilized world, we are going to see a real change, I think, in access to MR. The wonderful thing about micro ultrasound is it's in the urology office. You don't need to go get another test done. It's much less expensive. It's in our hands as the urologist, and we can make a decision about the biopsy on the spot. I actually helped design the trial protocol, the Optimum trial that just got published. It works. There's no question it works. It is a learning curve, just like MRI is a learning curve. They have something called the Primus scale, which is a lot like the PIRAD scale for MRI. And it works very well. I think the reality is those centers that are using a lot of micro ultrasound are using it in addition to MRI rather than instead of MRI. Now, I would say if it is a urology practice where the urologist has a pretty good volume of patients with elevated PSA and prostate cancer, and they don't have access to a good MRI facility, I would definitely take an experienced urologist with a micro ultrasound over an inexperienced radiologist doing an MRI any day. But the reality is most urologists that are doing micro ultrasound also have access to good quality MRI. We tend to do both. So I think it's going to be a wonderful adjunct, and maybe we'll replace MR in certain circumstances. Maybe for surveillance on AS, it will become an easier proposition. But MR is just so, especially outside of the US, it is so standard of care. I don't think we're going to see micro ultrasound as a replacement. But it's a great tool, and it's another additional tool in our armamentarium.
Thank you. Thank you for a great talk.
All right. So another question. I live in a rural area. There's 6 urologists in the area. Many men have Medicare Advantage and cannot leave the state. Okay. So first of all, there is this utterly insane rule in healthcare that for telehealth, if a patient drives to see me from Reno, I can see them and I can bill Medicare or their private insurance. If he gets on a Zoom to me from Reno, I cannot. This is probably the dumbest rule in healthcare. It was suspended for a while under COVID. It is now back in force. I will tell you that neither UCSF nor anywhere else is anybody checking IP addresses. And I've always told the guys, tell them you drove to Truckee and you're making the call from California, and nobody is ever going to check. So if you cannot leave the state, don't tell them I told you that, but nobody is ever going to check. So if you're looking to get a second opinion at some center of excellence somewhere, that is a path forward. I would also say, you being an Orange County group, you should definitely not have to leave California for therapy. We have access to absolutely everything there is to, you would possibly want and more. There's probably a lot of things you would never want. Proton therapy, for example. There's a lot of treatments available within the state. So, as far as like the counseling strategies to help men make better choices, by far the number one thing, get a second opinion at a center of excellence. This does not have to be an academic center. There are some very good non-academic affiliated urology groups. They're typically called LUGPAs, these large urology groups that have, subspecialist prostate cancer experts. They are more present in Southern California than in Northern California. If you're in Kaiser has some very good centers of excellence. There are some really good prostate-focused urologists in Kaiser, so you need to make sure you get a subspecialist within Kaiser. And honestly, the UC system is phenomenal here. So UCSF, UCLA, UC San Diego, UC Davis are all national leaders. UC Irvine, I would say, is a little bit less prominent on the international scene, but it still has some fantastic clinicians who know the space inside and out. So it is an easy thing to get on a Zoom call. You never have, any Medicare plan is going to pay for an in-state consult. You don't have to drive. Everybody is doing Zoom. We can't check your prostate over Zoom, but that's just fine. Get a second opinion. Even if you've got a Gleason 9, you've got time to get a second opinion from a subspecialist. Okay, it does not have to be academic, but you want somebody who, like I said at the beginning, eats, breathes, lives, and sleeps prostate cancer. You don't necessarily want the one treating kidney stones in the morning and maybe sees a prostate every few weeks. That's a great starting point. Okay, and with all great respect for my colleagues, this is a condition where the outcomes are very variable by the individual urologist, and you deal with the outcomes with the side effects for decades. So make sure you get at least 2 opinions. You can always get more. All right, recurrence post-prostatectomy doesn't. Okay, so sorry. So the question here, just to clarify what I said, the definitions of recurrence are different between surgery and radiation therapy, and they have different goals. And this is just sort of the way things have evolved through the specialties. So for years in surgery, in urology, we have defined recurrence, quote unquote, after prostatectomy as a PSA that gets to 0.2. Okay. The reasons for that is, number one, the PSA should be 0 after prostatectomy. No prostate, no PSA. It's very easy. It's very clean. And we want to identify men pretty early for salvage radiation therapy. So it's a pretty low threshold. So many men who recur after prostatectomy would never die of the prostate cancer because it's being driven by a low volume recurrence, for example, and it's not a big deal. And we do overtreat some of those without question. The definition of recurrence after radiation therapy is the PSA rose by a factor of 2, not 0.2, but 2.0 over the nadir, over the low point. And the reasons for this is that after radiation, we expect the PSA to be very low, but it doesn't necessarily have to be 0, because the radiation does not kill every single cell. The cells die off and they shrink and they involute, but they don't all evaporate. So the PSA we want to see go down to a low level and stay low, and it will bounce around a little bit and it can rise slowly. And the radiation oncologists picked this Phoenix definition years ago for clinical trial purposes, not to identify every recurrence, but to predict who is actually going to die of prostate cancer. So if you hit the Phoenix definition, that is, for better or worse, a big step toward, well, you might eventually have metastatic disease. That is a very different intention. It's a different goal from hitting the recurrence definition after surgery. So the two are not comparable. And as a colleague of mine many years ago did a very nice study where they applied the radiation definition to a surgical cohort, And if you use the radiation definition of recurrence in the post-surgical cohort, the median time to say you've recurred extended from like 2.5 years to almost 8 years. Okay, so we're capturing a recurrence at a very, very different point in the disease progression. So I did not mean to imply that a recurrence after surgery means you're fine, but it means something very different. And it means something not necessarily as aggressive as if you recur after radiation therapy. Is Center of Excellence actually defined? There is no list. There is a list of comprehensive cancer centers on the National Cancer Institute website, which you can certainly look at. I believe all 5 UC campuses have those designations. City of Hope, absolutely. Cedars-Sinai, absolutely. Otherwise, don't be afraid to ask people how often they do this. Okay, and what they do. Okay, the median prostatectomy volume by American urologist at the dawn of the robotic surgery era around 2007-8 was 3 cases a year. Okay, the modal number, the most common number done by American urologists was 1 case a year. 25% of the cases were done by somebody doing 1 a year. That is honestly nuts. Okay, some of them do a good job, but if they do, they shouldn't be afraid to tell you they only do 1 a year, and they better know their outcomes. Okay, so don't be shy, and don't be shy about asking your clinical team, is this what you focus on? Are you cancer focused? Are you prostate cancer focused? What's your volume? How often do you do surveillance? How often do you do surgery? Do you recommend radiation for 90% of your patients? And if they're offended by these questions, go see somebody else without question.
Are you suggesting a fee-for-service model?
This is fee-for-service model in most cases. I mean, at the UC campuses, we're salaried, which is kind of a nice thing. So is Kaiser. We have some incentive for volume, but it's a nice thing about being salaried is I am not driven to do unnecessary treatments, which is a good thing. There's a lot. It's not just fee-for-service. There's a lot of intangibles. There's a lot of problems in the way the healthcare system is kind of organized. There's all kinds of things. So that's a whole complicated question I don't want to get too far into. But I will say that we should regionalize more than we do. We have these incentives for people to keep patients who frankly shouldn't. This is something the UK does very, very well. You get a PSA test in primary care. You get a biopsy by a community urologist. The minute you've got a prostate cancer diagnosis, you're in a multidisciplinary setting. There is no community management of cancer by people that are mostly taking care of kidney stones. Okay, we should do that more in this country. And again, this is not Kansas. Even rural California, you certainly have easy access by Zoom, and not if you're up in Trinity, I get it, but certainly Southern California. Nobody's more than a couple hours from a big center. And again, Zoom has revolutionized things. I mean, 5 years after COVID, I think 70% of our practice in urologic oncology is still Zoom, and it works great. It is easy to get a second opinion, even if it's just like midstream and you just want somebody to check over your record and make sure that things are going fine. You like your local team, you want to stay with your local team. It costs you just a little bit of time, and nobody on the university side is ever offended that you're just getting a second opinion. That is why we are here.
Midstream is an excellent example.
So to speak. Hopefully a well-controlled stream.
And just FYI,
And that's something else I'm going to say. Sorry. On that note, I'm just going to throw that out since it's a support group. We hear all the time of men that are out there after treatment with problems who are suffering in silence. And this is another reason that you want to get yourself seen at an academic center. If you do have long-term urinary problems, sexual function problems, bowel problems after surgery, radiation therapy, or even focal therapy, and these have not been fixed, get a consult at a place where they take care of these problems. Okay, and again, that's any of the UCs, Kaiser, etc. Leaking 3 pads a day, 2 pads a day, 3 years after surgery, that is not how things should be, and we can fix it. So just bear that in mind too.
We have just added to the website a list that we called Southern California or SoCal Centers of Excellence.
Yeah,
so
great.
It gives you links to these places, to their websites, to portions of it. So check it out there. It's all in one place.
Yeah. And we're one state. I mean, I see folks from SoCal, Davis, UCLA sees our patients. It's not where it is very, very easy. So that's probably the take-home message is get second opinions.
Yeah.
All right, good. I hope this has been helpful.
This has been wonderful. Thank you very much. Anybody else with a question for the doctor before we say thank you to everybody?
Thank you very much.
Yeah, thanks for coming.
Yes, as I said, it was exciting, exhilarating. We'll be getting it up on the website pretty quickly. So thank you very much for your time.
Can I add quick.
Thank
I'll be down. I'll be down at PCRI at LAX in a few weeks. I think if any of you come to that, so maybe I'll see
All
some.
right, yeah.
Can I ask one follow on?
Of course, go ahead.
Okay. I understood what you're saying, recurrence post-surgery versus radiation. Okay. And what I gather, when you're 12 years out
Yes.
with a PSA of 1.5
Yeah.
and 2 negative PSMA PETs,
Yes.
I'm looking at this like,
Yes.
I can wait. I can wait. Probably I can help to wait a long time.
Yeah, like I said, nobody ever died of a PSA. Okay, so this is where genomics are quite helpful because I've gotten, you can get a decipher even on a 10-year-old prostatectomy specimen, and if it comes back really low, it's always a little bit tricky to say just stop checking the PSA, which is kind of what I want to say in cases like that. If you still have 15-year life expectancy, it's a little bit hard to say that, but that's kind of what we should say. I will say very occasionally, for a situation like you're describing where the PSA is just drifting slowly. First of all, look at the pathology report and see if the benign margin, you might need to get the slides reviewed, but it's important to read out a benign margin as well as the cancer margin. Because sometimes the margin is negative, meaning there's no cancer, but it's easy to leave a few benign prostate cells behind next to the sphincter muscle. And those can grow and those can produce a little bit of PSA. And I mean, once in a very blue moon, I've done this a handful of times in my whole career, we will put people on finasteride, which is the drug we use to treat BPH, just to knock the PSA down because it makes everybody feel better. It's not doing a single thing for cancer outcomes, but it's just treating the anxiety associated with PSA. So
And it makes your
I
hair
don't care
grow.
about anxiety.
exactly.
And I'm 80 already in good health. So
Yeah.
15 years, I'm not even
Yeah.
10. Yeah. 15,
At
who knows?
some point you can stop. You got to
Yeah.
talk to the doctor. Yeah.
Doctor, fantastic.
Great.
Absolute
Good.
fantastic.
Wonderful.
Thank you.
Nice to see everyone.
Thanks, everybody. Thank you,
Thank
Doctor.
Same.
Bye-bye.
Thank you.
Thank you so much.
Thank you very much.
Fantastic, doctor. Thank you.